Everybody to the Free2Care virtual conference. Free2Care is a 501c4 organization. We do not, we're not tax exempt or provide tax deductible donations, principally because we want to be involved in legislation and advocacy. And we've given ourselves the freedom to do that. We operate on a very simple mission. Healthcare is about the relationship between doctor and patient. And we seek to remove any third party that doesn't add value to that relationship. So everything that we do is stemming from that singular mission. This organization celebrates its 1-year anniversary this month, which is really quite remarkable when you consider what we've done in that year. I think it's also fitting for us to celebrate those things that we have done. Please allow me to just mention a few of them. It's certainly not an exhaustive list. We had our first conference on April 1st in Washington, D.C., where we had Secretary Ben Carson address nearly 100 physicians in the Library of Congress. We also released our Reducing Cost and Waste from American Healthcare white paper, and it's been distributed widely ever since. The paper outlines 5 platform issues of our organization, and we have exercised a great deal of discipline in sticking with those issues because of that paper, we have been able to grow our membership amongst conservatives, liberals, and across the spectrum because they believe in that mission that I expressed earlier. Our membership, speaking of that, in only 1 year, we have grown to 21 member organizations, and we are we're an organization coalition. We don't take individuals because we do not intend on competing with our member organizations. If there are individuals, we very happily point them in direction of the various groups, depending on their interests or inclinations. So we have 21 member organizations representing nearly 2.3 million individuals nationally, and that includes 37,000 physicians. We have supported bills, we oppose bills, and you can find out more about that on our website, which is free2care.org, and it's free, the number 2, care.org. Our successes are the successes of our member organizations, and some of those that I want to highlight as part of this list is what Physicians for Reform has done with the Job Creators Network in establishing a framework of a replacement of our current healthcare system. Physicians for Patients put out a petition that they've received nearly 25,000 signatures, and they got the attention of the White House that resulted in a meeting with senior staff, and multiple op-eds have come out after that. And in fact, members have been writing prolifically and have appeared in publications such as the Wall Street Journal, The Hill, National Review, and a variety of others. As a group, we've met with the staff of the Senate Help Committee to give them our input. And actually, they requested our input based on some letters that were sent that way. We've worked tirelessly to kill bills that impede great models such as DPC. Everyone came together to support direct DPC action to make their voice heard on House Bill 3708. And again, so many other things that we could discuss. I don't want to take up more of this time, but I'm happy to share those with you. But ultimately, that's what Free2Care is about. It's making the voice of the patient and the physician heard. And I want to thank everyone that is here for the contribution they make in making this coalition not only a reality, but a success. With that being said, I'd really like to extend a great deal of thanks to Citizen Health. They have worked tirelessly to put this together, and producing this conference, and what they have done or what they do is they're a technology cooperative that is building a marketplace to empower physicians and patients, and that's why they work so well within our mission. And I'd also like to remind everyone today, one of the accomplishments that I didn't mention that is very important because we're going to honor them today is the work that has been done by Practicing Physicians of America. They and Dr. West have been so dedicated to this litigation against Bloch, which is, again, impeding the doctor-patient relationship. And we are giving a percentage of the proceeds from the donations we're receiving for this conference to their effort, and I hope that you'll contribute to that. And with that being said, I'll defer now to Brennan and have him talk about the run-up show.
All right, thank you, David, and hello, everyone. I want to give kind of some ground rules here and what to expect for today and tomorrow. So today is the first day of a 2-day conference. We have 4 hours today and 4 hours tomorrow. So 4 panels each day. And we're using Zoom for everything. So please take advantage of the chat options on Zoom, questions and answers. And we do have some polling options if the moderators and panelists want to poll during the session. We can do that. So all of this it is being live streamed on YouTube right now, and will be broken into each panel with its own particular video at a later date. But right now it is live stream. It will be on the internet forever. So just to let you know that the chat transcript will also be posted as an article along with the video. So all of this will be documented, and we're going to be sharing it around our social media channels to really generate a lot of activity and support for these organizations. So with that being said, our first panel is Navigating Hospital Politics, and it is moderated by Dr. Kat Lindley. So Dr. Kat, I will turn it over to you and go from there.
Thank you, and good morning, everyone. Kat Lindley. I'm a direct primary care physician in Texas, and it's my honor to be on this first panel today. And we're going to talk about navigating the hospital politics, and who better than 2 gentlemen who used to be hospital executives. We have Mr. David Balat, who is the Health Policy Director for Texas Public Policy Foundation, and Mr. John Chamberlain, who is the president of Citizen Health, I believe. Between 2 of them, I believe there's some 40-some year experience in hospital work, and we'll hear from them and have them talk. First, I would like you guys to introduce yourself to the audience, and then we'll start talking about some hospital politics.
John?
Hi, good morning, everyone. My name is John Chamberlin. I'm currently serving as chairman of Citizen Health. I have over 40 years of healthcare experience, predominantly in hospital executive roles and physician practice management. And of late have become, actually have always been very impassioned for patients and certainly physicians, because those 2 form the basis for true healthcare in this country. The physician-patient relationship has been usurped of late, and it needs to be reestablished without third-party interference, hence the name Free2Care. So I look forward to answering questions this morning and talking about how to successfully navigate hospital politics. Thanks, everyone, for being here.
My name is David Balat. I'm the Director for Health Policy with the Texas Public Policy Foundation. I started in the hospital industry. I started when I was 15. I've worked through every department you could probably work in the hospital, and decided to go that route. Even though I was pre-med in college, I worked in ER and ICU, but then worked for some of the big hospital Sisters of Charity is where I got my start, and then in the Memorial Hermann system in Houston, Texas. I didn't play too well with a lot of the corporate types, so I went off on my own and did turnaround work, and I did that for about 7 years, and that's where I found my real joy, because what I found was that if you partner with physicians, the hospitals tend to do well, and that's why many of them were run nearly into the brink of bankruptcy, which is just a shame. And John and I saw a lot of the abuses that administration has imposed upon the physicians who they should be partnering with, and we wanted to again impart what we know that could be of service to you all having to deal with those administrative individuals and rules that they use to hamper your care for your patients.
And that said, actually, I used to be employed by a hospital, and it's always difficult to navigate, through those politics and things like that. And from several friends of mine, I hear that when they, start working for a hospital in a clinic or a hospitalist or whatever, they don't have to supervise anyone. Then all of a sudden it becomes part of their contracts where they have to supervise the nurse practitioners or PAs or things like that. How do you guys, what are your experiences with that? What are the rights that the physician really has when it comes to that if they don't feel comfortable supervising someone?
John, if I can jump in, I think we need to think about it in two separate types of scenarios. What Dr. Lindley just brought up would be an employment contract. And I think what would be best is for us to take one at a time and talk about what are your rights as an employee versus what are your rights as someone with privileges in a hospital. Wouldn't you agree?
I would agree.
And so it always starts with a contract. Whether you have privileges or you're an employee, know your contract. Have an attorney read it. Understand what your obligations are and understand the nuance. That goes for the bylaws as well, even if you're not an employee. Understand the rules of the game because they will be used against you at times. So it's always important to have a copy because you'd be surprised. So many physicians that I knew of that did not have a copy of the bylaws and happily give them another version so that they could be prepared. But many wouldn't, a lot of people would not do that because they'll weaponize those bylaws against the physicians.
And I think the distinction is correct, David, that you have to differentiate between being an employee where your options are limited, again, by your contract, as opposed to being a community physician that has privileges. And again, it depends on what privileges, what level of privileges you have. But I think it's important because I guarantee you, those of our brethren that are still employed by hospitals as executives know those bylaws backwards and forwards. They have an army of attorneys that know those bylaws backwards and forwards, and it would be probably one of our number one recommendations that as a participating physician in a hospital, whether employed, which again reduces your options, or more importantly, particularly as we see DPC growing, that are not going to be employed by anybody for that matter, except their patients. If they do indeed utilize a hospital, they need to know what their options are and how they're going to be impacted. So it's very wise to have that not only reviewed by an attorney, but know those bylaws to the best of your ability.
So another question that came up in discussions is actually from some physicians who are specialists or even family medicine physicians who are not part of the hospital group, who are still independent. There is a trend across the country where the hospital kind of starts isolating them and starts putting maybe employed physician hospital, and all of a sudden all of the referrals go to that person and not to the physicians who've been in the community for 20, 30 years and things like that. What are some of the strategies that you guys think these physicians could do? Because I know of several cardiology groups and even a primary care physicians who have had to leave the community because there was no more referrals sent to them, so they couldn't survive.
I think it all comes down to primary care, and the hospitals have that figured out, and that's how they try to manipulate and control really all physicians, but especially the specialists. It's important for your primary care physicians to understand. It's shocking to me how few of them really do the power that they have. Nothing happens without that referral. I learned very early on that nothing happens in a hospital except for at the tip of a doctor's pen. And so if you can support your primary care physician, you can encourage your direct primary care doctors. If you can control your referrals, you have some influence over that hospital. They treat you in a completely different manner. But what I've also seen is even physicians that have a huge referral source, if they don't demonstrate their knowledge of their value, that they will still be bullied in a sense by hospital administration. I think John has probably seen a good bit of that as well.
Yeah, I think too, it's not just primary care physicians and specialists. I had a fairly recent event here. There was a freestanding imaging facility, probably had the best equipment from New Orleans to Tampa. And essentially the hospital-owned physicians, at the instruction of the hospital, stopped referring to this freestanding center and essentially ran that whole center out of town. And that's a shame, because it was not only a very accessible facility, same-day service, low-cost cash offerings. It basically, they eliminated the competition. And I think, again, David's exactly right. The most expensive piece of equipment in the hospital is not that 3 Tesla MRI. It's a physician's pen. And that's a good thing, because they do control. There's not a hospital administrator in the country that can admit patients to the hospital. The only ones that can do that are physicians. And again, primary care docs, those independent specialists, need to understand what their value is, and those that do certainly should be able to pronounce that more. And don't be afraid to go to the hospital execs and say, look, I put a lot of patients in this hospital. Now, obviously, it's a lot easier if there are other facilities where they can move their patients to, but in those situations where there are not, it is tough. But I think, again, you go back and look at primary care, and one of the real goals of primary care, and especially DPC, is to keep patients out of the hospital to begin with. So that's another arrow in the quiver, if you will, that primary care docs have. And again, if you have the opportunity to refer to specialists outside of the hospital that are not employed by the hospital or not affiliated, that's what you need to do. If you can get specialty care via other means besides hospital-related specialists, then that's what the primary care docs should do. It's a difficult situation, and the bottom line is that even today, hospital and physician interests are not aligned. Incentives are not aligned. Now, there's a lot of PR, if you will, on the hospital side about, our physicians, we all think alike. Not necessarily so. If a patient's not in the hospital or not receiving hospital-related services, that is not an aligned incentive. So again, I think primary care especially, as David said, is what it comes down to. Do everything that a primary care doc can do, either in office or with specialty care outside of the hospital, for a whole host of reasons. The least of which is not, if you send a patient to a hospital-related facility, they're going to get charged an additional fee, known as a facility fee, that they would not see in an independent service provider.
So as a primary care doctor, I agree with you guys, but I actually found that the hospital does the opposite, right? They hire the nurse practitioners or mid-level physicians, and because they want those referrals to stay in the hospital, and they don't necessarily want a great primary care doctor who can do a lot on their own, because the hospital needs revenue with those labs and CT scan and MRI. So it's kind of interesting to hear you guys talk about that, because you talk about it from the patient and physician perspective. You're not talking anymore as a hospital executives, which is kind of nice. I know you both, so I know where your hearts are, and it's kind of nice to see that. But we all see that other side where they want to keep everything in-house to generate revenue.
You're absolutely correct, Kat. That is still today. That's where the money's made. Whether they're admitted as an inpatient or admitted to outpatient services, that's where the money's made. And David and I both, I think I can speak for David, we saw the error in that several years ago. And what we saw was a decline in the quality of patient care and actually a focus. And I think, honestly, to be fair to myself, David, and other hospital execs, at one point in probably all of our careers, we had this more altruistic approach to care, that you took care of the patient the best you could as a hospital. You took care of your physicians so they could take care of the patient. Then everything else worked its way out. Well, unfortunately, as legislation was enabled, I could go on a whole rant about it, but I won't. The focus became money, the money became what drove not a healthcare system, but a sick care system. So in other words, if patients are not being treated for serious issues which require lots of ancillary services, labs, imaging, et cetera, then we don't need them. They're not making us any money. So good luck with that. Insurance companies certainly enter into this whole thing in that the more money the hospital charges, the more money insurance companies make because of the medical loss ratio rule that's in play right now. So I think the incentives are still very much misaligned. David and I both, and I know David well, we both focused on patient care and our physicians our whole careers, but it became more and more difficult to do so in that hospital environment. And we both chose to change our pathway. And
I love what I do now, but I miss the hospital. I'm one of those strange.
I miss buying all the really neat toys. But, you know, the fact is they're toys to a point, but that's one reason hospitals have remained successful is they are the deep pockets that can afford equipment that physicians, as we drive more and more to a sick care approach to providing care, they're the only ones that can really afford the fancy equipment.
And you know, hospitals aren't necessarily, I'm not going to say, we're not going to this isn't an effort to demonize hospitals. Hospitals have a great value. John was talking about alignment. The incentives are not aligned. And so you as physicians have to demonstrate your value and demonstrate your power so that you can take the best care of your patients, because that's ultimately what's important. But so let's talk about some certain situations that you've seen, John, and perhaps some from my history. Here's another piece of advice that I think would be important. If you're called into credentials committee, there's some kind of discipline that's looming, and it starts to progress, and they say, well, we're just going to come talk. Don't worry, it's okay, which they'll always try to make things a little bit more relaxed than they really are. I would always recommend that you bring an attorney with you. Check your bylaws to make sure that that is something that is not prohibited, because if it's not prohibited, then it's allowable, as far as I'm concerned anyway. If they refuse to have that meeting because you have an attorney there and it's not prohibited by the bylaws, you've done nothing wrong. But I was going to say this at the end, but I think, John, and I don't want to speak for you, but knowing you, I think you'll be okay with this. But if anybody does run into these kinds of problems, we'll be happy to provide some guidance and recommend attorneys that might be of help that have this kind of experience.
Absolutely. I think another scenario that I heard a lot about, particularly having worked in some academic medical centers, also it still applies in even community hospitals, is the new version of what's called town gown. You had community docs and you had academic docs. But I'd like to take it really to the community level, where you've got, let's say, independent physicians that have, let's say, minimal staff privileges, but because they may admit, 3 or 4 patients a year traditionally, and they get basically courtesy privileges that allows them to admit, let's say, less than 12 patients a year. The problems that raise their heads is really in scheduling, whether it be surgeries, whether it be outpatient procedures. And there tends to be a scheduling difficulty for those independent docs as opposed to the owned or employed. And I don't think a lot of docs like to say they're owned, but if they're employed, they're owned, in my opinion, because their life is not their own. They have no really decision-making ability. But what I'm trying to get to is the dichotomy that exists between employed physicians and independent community-based physicians that have difficulty in scheduling patients. And a lot of that is due to the fact that they're going to take their own first. And it's wrong, but it happens. And I think that's something, again, that the physician that is being discriminated against, if you will, needs to take it up with hospital administration. If hospital administration is not receptive, then take it up with hospital board. because patients are not getting cared for in a timely fashion, and that should not be allowed to happen. And somebody needs to know about it. And again, as David said, if need be, bring an attorney.
I actually have a couple of questions here from Dr. Thompson there related to what we talked about. So her question for David, can you give an example of how to demonstrate how physicians can demonstrate their value and power to the administrators? I think you guys touched a little bit about it on it with the fact that with the primary care and all that, but what about all the physicians just in general?
That's a great question. Referrals, admissions, looking to see what you bring, getting to know as much about what that patient represents to the hospital as possible. Because if you're, a general surgeon and every patient represents $10,000 and you're bringing 100 patients a month, you know what you're worth to the hospital. So it's important for you to get to the metrics. Some hospitals will do it for you. Some have, they started doing that, but then they got away from it because providing that information was more detrimental to them in the way for them to control their docs. So everything is more secretive, as we see in healthcare generally today. But that's what I would do. Create a dashboard for yourself, or have your staff do it. But, how many people are you referring to the hospital? How many patients are you referring to a specialist that end up in a surgical procedure if you're a primary care doctor? Know where your patients are going and know what they represent financially to the hospital, because that's the only language that they speak. I'm not making any friends when I say this, but today the hospital administrator is really no different than a glorified hotel manager. They're not partnering with physicians. There's very little entrepreneurship. They're following policy and building buildings and buying equipment. And there's nothing difficult about that. I'll let you address the question if you have anything to add.
No, I think you're exactly right. And I think there's the mindset of a hospital administrator today, certainly even before I left the field, you tend to look at your top 10 or top 15 admitters, make sure that they're ginning like crazy. Sometimes that second tier gets overlooked because they're not the big admitters. And so I think what David said, I would agree with. Stand up for yourself, do that dashboard. There's all sorts of data out there right now that say that let's say, for instance, and don't hold me to the number, but the average primary care physician in this country is responsible for well over $1 million. I think the one for the average PCP is at least $1.2 million worth of revenue to the hospital. So again, you can break that down, but look at your own dashboard. And I think that's important. You need your voice to be heard. We are trying through certainly Free2Care to have a collective voice being heard, not only by hospitals, but also by the government, insurance companies, et cetera. So I think it's important to stand up for yourself. Again, David, your suggestion of having your staff pull, let's say in the last 6 months, how many admissions you had, how many surgeries you did, how many referrals you did for specialty care, how many referrals you did for ancillary services is important. And that's probably the best way. Hit them in the wallet. Let them know what you're bringing to their hospital and that you need to be recognized for it and you need to be appreciated for it. Again, it makes it a lot easier if you have, another facility in town. You just say, see you later. They'd be happy to take your business, provided certainly the quality and other things, ease of getting patients in is equal or better at the other facility. But you've got to basically stand up for yourself and say, this is what I'm doing for your hospital, and I need these things to happen to make taking care of my patients better, and I'd appreciate your assistance.
Kat, I wanted to address something from earlier, another tool to help physicians protect themselves from administration, because they'll set doctor against doctor, and there will be a lot that goes on, and there'll be phone calls. If things start to spiral, I would always check with your state. Texas is what we call a single party state, as long as one person is aware that the call is being recorded. It's legal and admissible in court. So you want to check to see if your state is a single party state so that you can, record conversations in the case that you want to remember or take notes on that later. But anytime there's a verbal interaction, a conversation, a meeting, a phone call, it's always best to summarize that meeting and send an email with the understanding of the contents in that email to that person you spoke with. You're creating a data trail. Just like in your clinical practice, if it doesn't get written down, it doesn't happen, right? Same thing in these situations. Document, document, document. The more documentation you have, the better that you'll be able to protect yourself.
I think another way that hospital administrators would like physicians to move these issues to their attention is through the medical staff organization, whether it be through committee, whether it be through the CMO if you have a chief medical officer. Unfortunately, in some of those situations, CMOs are in the position they're in because of their, relationship with the hospital CEO and the board, and it may not be there in the best interest of the medical staff members, individual medical staff members. But I think that's probably, at least it was when I was still actively involved, that was the preferred initial approach, was through either chief of staff or CMO or department chief. I mean, it's this layer upon layer, which is one reason they do it. It's called a stall tactic. But I think that's certainly another option. But if it was me, knowing what I know today, I would go directly to the CEO. And, if they throw up a buffer, fight it. Say, I really need to speak to you. I don't want to speak to so-and-so. I know so-and-so, but I haven't had success in getting things done or being listened to. So again, I think that's what's going to happen to a lot of physician issues. They're going to be told to go up through the medical staff organization.
Buck stops with the CEO. Patient safety is always my responsibility. If you don't have a safe hospital, you can't have a profitable one.
And I do appreciate your advice, guys, because, even for myself, some things that I went through, I've never been my own best advocate. And having these conversations where you kind of stick up for yourself and try to explain, and even when you're negotiating contracts, sometimes you just feel, oh, I'm so thankful they gave me something, so having you guys give this advice from your perspective, it's really valuable to me. And I know it's probably going to be valuable to a lot of physicians to understand that we do have a voice. I think we've been told for so long that we don't, that it's sometimes too hard for us to stand up for ourselves, which I did have a question either one of you can answer, but let's say no one listens, CEO doesn't listen, and all that, who do you go next to?
Before I answer that question, I want to say something. And if I may, Kat, I hear what you just said from many, many people, and I want you all to change the way that you think. You're not sticking up for yourself. Stop thinking that way, because people tend to be, especially in altruistic careers, they don't want to negotiate for themselves. They're not very good negotiators. They don't want to stick up for themselves. They just kind of take it and go on and do what they were trained to do. Stop that. Don't do that anymore. Don't stick up for yourself. Stick up for the patient. You are there for the patient. And the fact that they're impeding your ability to care for the patients, they're harming patients. That's the way I go, and I guess that's why I have the intensity of fight that I do, is because I see everything that I do for the sake of the patient. And it's not about David, it's not about Kat, it's not about John, it's not about anybody on this call. It's not about anybody that's viewing this video. It's about the patients. And are we going to defend the patients of this nation and give them the best options possible? So go in there and fight for them, not for yourself.
I concur 100%. And guess what? We're all patients. At some point, I've been a patient several times, and my knowledge of hospital world and how things should work as a patient benefits me greatly, has benefited me greatly. I know what to look for who to look at, who's doing what. And I think that's important, but I agree with David 100%. If we keep that in mind, and I said that earlier, if we keep the patient number one as the central focus, and hospitals need to look at physicians as partners in taking care of patients, not as some means to an end, which unfortunately a lot of hospitals look at physicians as a revenue source. And okay, I understand that's business, but again, I go back to something I learned a long time ago. Focus on the patient, take good care of the patient, and as long as you have appropriate protections in place from a financial standpoint, insurance, et cetera, everything is going to work out. But a lot of hospitals, certainly due to all the focus on revenue, I mean, we're a $3.67 trillion industry. There's a lot of money out there. And we need to get back to that. We need to get back to focusing on the patient. I'd like to go back to something that you said earlier, Kat, about, you gave a good example of, as an employed physician, there was no mention in your contract of being responsible for supervising mid-levels. Or if there was, you didn't have your attorney catch it. But the point being, all of a sudden those things change. And the sad part about that is hospitals are hiring mid-levels, in my opinion, more and more because they're less expensive, they're a little easier to control, and they still can perform a lot of the things that physicians do at a higher cost. But to put physicians at liability, because in actuality, if you're supervising a mid-level, you're ultimately liable. And believe me, hospitals have attorneys for one reason. Well, a lot of reasons, but in this particular situation, they're confident that the first line of defense, if something untoward happens, is you as a supervising physician. And I think that's certainly an issue that needs to be remembered, that we've got to take care of our docs, we've got to take care of certainly the patient, but that's not the way to do it. And I think that anytime an administrator wants to, put that onus on you, then your contract needs to reflect it. You need to have an opportunity to respond, get your attorney involved, and make sure that you're not opening yourself up for more liability than you already have.
If you are supervising mid-levels, we were talking about a dashboard earlier. Include that dashboard as part of yours as well, because
Right.
Again, under your supervision, under your license.
That's correct.
And I agree with both of you. I know we've spoken several times. I feel that if we could go back to that time when physician and patient relationship was the most important one, that all things would align, and working with a hospital as a partner, it would be amazing. But in lots of circumstances, now a lot of physicians is not that way anymore. They do see us as just part of the workforce, but not as partners anymore. And I know a lot of physicians are getting frustrated and kind of pushing away from it. And in my case, for me, direct primary care is great because I can shop around for my patients and find what's best for them. I'm not dependent on that hospital, but a lot of physicians are, and it's a difficult environment now. Healthcare is not what it used to be anymore. It's like you guys said, it's an industry. It's probably one of our biggest industries in the United States, and everyone wants a piece of it. And I know hospitals have a huge lobby in DC, and every time we're trying to promote something for betterment of patients and physicians, there's always, something you have to fight from them as well.
Well, it's been known for a while, and I think it's certainly not any truer in the past than it is today. It's been known as the medical industrial complex. And that came from actually an Eisenhower era description of the military industrial complex. And we've kind of changed places now although the military is certainly well-funded, healthcare is way more well-funded, as I said, to the tune of about close to $4 trillion. And as you said, Kat, you're absolutely right. Everybody wants a piece of it. And more people want a piece of it because they see the revenue. And I think one other thing you said, which this is very discouraging, that, and David, correct me if I'm wrong, or anybody actually listening, but I think that we've now eclipsed the 50% threshold of employed physicians. By the time and it's not, and I think a lot of times people don't understand, it's not just hospitals that employ docs. Look at United Healthcare through their Optum division. They employ 100,000 docs. Humana employs 33,000. I mean, it's a frightening statistic. And so let's say 51% of the 900,000 docs in the country are employed. That means that many doctors really have no individual latitude in decisions that they make. They're no longer free to make those decisions.
Well, and they're hamstrung because hospitals automatically make more money because of the facility fees, which is why we're fighting for site neutrality. That's one thing. The other thing is this silly moratorium on physician-owned hospitals. When you talked about having your incentives aligned, that was when it was more aligned, is when the physicians were the owners of the hospital because they were looking out for patient safety and they were able to augment their income. And then you look at the other thing, yet another thing that we're looking at really bringing more attention to is these tax-exempt hospitals. I don't call them nonprofit anymore, but they're benefiting from this tax-exempt status, and they're saying that they give charity care, but they're basing all of this supposed or alleged charity care on the discount from their charge master, which is an astronomical, fictitious number. So they're playing a shell game and manipulating the system for their own benefit, and they're not helping patients. And that's just, again, there's a reason why I'm not in that business anymore.
Same reason for me. And I agree, this uncompensated care, this discount from bill charges, that is a shell game that is unbelievable because there's no control over charge masters. And, this recent effort by CMS to get charge master pricing out, well, that's a jumbled mess, and there was no guidelines as to what format it had to be put in, so to speak. And so you get a poor patient that's going to look at a hospital charge for, let's say, just a laparoscopic cystectomy. And I'll give you a perfect example from personal experience. I had one of those about 2 years ago, and the bill charges that I got from the hospital that I went to were over $76,000 for a lap chole.
Oh, you had a discount.
Yeah, I had a discount. The funny part is, being a Medicare recipient, you know what the hospital got paid? $12,000. So they billed 76. They got paid 12. The 64,000 went to, guess where? Uncompensated care or contractual allowances, so to speak. Now, for somebody without insurance, the hospital, and I asked the question because I've been in the business, I said, what would you do for an uninsured patient if, in the first place, you allowed them to have the procedure there? They said, well, we would give them a 50% discount. I said, oh, that's generous. So you're only going to charge them $38,000 for a lap chole? That's unacceptable. And that's really a very good example of where we are today. It's not laughable.
That's just the facility fee. It doesn't include the physician and anesthesia.
That's right.
Whatever else may be the case, whatever they order.
It was well over 80,000 by the time that came to be.
So you guys are going to, well, I think you're going to be proud of me. So you both know I do a lot of advocacy and all that, and I'm currently president of Texas ACFA, which is the Osteopathic Family Physicians, and I was asked, where do you see family medicine going and things like that. And my answer to when people ask me, how do you think we're going to healthcare and all that, is that physicians, we have to wake up. We have to wake up and realize that we don't need to be employed. There are other venues for us. We need to I call it unplug from the matrix. I'm a huge Keanu Reeves fan. So we have been it's almost like that movie Matrix. You've been kind of preconditioned. This is what you're going to do. And you finished residency and you have so much debt. And you're like, okay, I'm going to go get this job because I need to start paying off my debt. we don't realize that there are banks that are going to give us loans because we are good investment. And, I really think that one of these days, I'm hoping that we can have this physician revolution where we realize that medicine, healthcare doesn't function without us. So we need to take back our voice for our patients and start saying our patients need us and you need us. So we can all do this together, or we don't have to. And I'm a firm believer that physicians start going back to independent practice of medicine, the whole healthcare system will be better because we are the true advocates for our patients, not the hospitals. So what are your thoughts about that?
Sorry.
Siri is going to answer.
Well, I couldn't agree more. I think, again, that's certainly part of the reason that Free2Care exists, is to help get this physician voice collectively heard. And you can't do it you by yourself, DPC Action by itself, any of the direct primary care associations or groups that are out there currently. They're all great, but it's still a very almost inaudible voice. And so the need is there for an organization like Free2Care. And there are a couple of others that are looking at the same concepts that we're currently via Citizen Health talking to about why are we all going in different directions in different groups when we should all be headed in the same direction. And again, I think the bottom line, I certainly know this for Free2Care, is physician voice and patient voice. And those of us on the periphery, if you will, from an administrative standpoint, David and myself, David's a little more involved, well, a lot more involved politically than I am. But I think, again, that's where the sausage is made, if you will. Nothing happens without appropriate legislation, but without the appropriate voice being heard, that legislation, and it's a perfect example is HR 3708. That's currently it's already rolled out of Ways and Means. It's got some bad stuff in there, and it does not need to go be approved in its present format. Section 5 of the recent executive order on saving Medicare. Again, the rest of the executive order is pretty good, but Section 5 is horrible. And if we don't have a loud enough voice, it isn't going to matter. It's going to be legislated through, and we're going to all suffer the consequences.
Well, and as I said in my opening statement, I couldn't be prouder of the activity and the actions and the groups coming together, because we put out a call on an issue, and boy, these member organizations of this coalition know how to rally. But Kat and John, we've got some questions that we have not addressed, and we're coming towards the end of our time. I just wanted to make sure that we address some of them. The ones from an anonymous attendee. You don't have no anonymous attendees. Come on, guys. Let's see. It says, with impeachment slowing down the legislative process in Congress for the next year, what do you expect Congress will actually get done over the next year? Absolutely nothing.
As long as they don't pass 3708, I'm good.
Well, you're not going to get a lot. There's not much that's going to get done in a divided Congress. When whatever good things the president can get done through an EO will be demonized in public. There was the relaxing of the waivers under Obamacare for the states to create more innovative models, and there was a vote in the Senate here recently, and that was it was voted down along party lines. But make no mistake, it wasn't about healthcare. It was for political posturing, which is what you'll see for the next year or so. The only way something will get done is if you have a majority party in every branch or in every chamber. Let's see, another question is, admitting privileges and physician contracts are hardly contracts, they're more mandates. Do you have recommendations for physicians for how to truly become negotiators for themselves? John, you got a quick
I think, again, certainly, reach out to an attorney. You should have one, at least, that you're involved with in establishing your practice or for other reasons. seek their advice. But there are lots of folks like David and myself that would be happy to provide, some assistance in that. Find somebody that you trust, a good business person, and tell them the situation and say, look, I've, whether it could even be family. You may have, a family member that's got an independent business that could provide some assistance in that. But there are ways to get that information. And again, it's some of the things that we've talked about today. Take it upon yourself. Get your arrows in your quiver and go. I know, as Kat said, it's not necessarily something that physicians have been known to be famous for, some more so than others. But if you're not going to stand up for yourself and basically put together the information you need to negotiate, then you need to either find somebody that will help you do that. But to just sit by and idly, suffer the misfortune that you might encounter isn't an acceptable answer. But I think, again, reach out to somebody that that's successful in business, that maybe has, I'm not going to say go take a negotiating skills course, a Charlie Karras course, or what have you, but you have to distance yourself somewhat from the day-to-day if that situation, occurs, and find yourself some assistance to do that. It is possible to do.
Let me just jump to a question from Dr. Sussman. How do we fix site neutrality, surprise billing when judges keep shooting these interventions down? Pressure from patients would help our cause. The powers aren't going to listen to physicians. I agree and disagree. I do agree the patients are going to help, but the physicians are going to have their voice will be listened. But it's been difficult when it's been fragmented in the past, which is why there's this the benefit to having this coalition coming together, having our voices magnified, patients and doctors standing shoulder to shoulder and saying, no, that's not right, and doing all that we can and making phone calls and writing letters and sending emails and doing what we do best.
And David, if I can also answer that from my standpoint, I found that we as physicians have done a poor job in the past. The coalition is great, and I 100% agree with everything you said. But you also, and this is something that we as DPC Action do all the time, you have to go to DC. You have to meet with them face to face, or go where they live, if they live in the town close to you or a few hours away. You have to meet with the staffers. They have to know you by name. My senator staff knows me by name now. And that's important because otherwise they don't hear from us. And when they don't hear from us, they think that we agree. So although I agree with that, the coalition is the way to go. Once in a while, you have to show your presence. And David does it for us all the time, but physicians have to stand up and invest their time and money into it as well.
John, I've got a question here for you from a physician. And the physician says, when I document hospital deficiencies, I've been called in and told to stop. How would you advise that person?
I think if you're not getting heard, and it depends on who's calling you in. If it's administration, then you need to go to your medical staff, your CMO or your chief of staff, and say, you're trying to bring this to the attention, or go to the quality committee. Whatever the case may be, if you still have no success, find yourself a board member because they have the ultimate fiduciary responsibility, certainly in these tax-exempt facilities. Now, that's not the case for the for-profit hospitals. Boards in those situations are purely advisory for the most part. But find yourself a board member that's, again, they're ultimately fiduciarily responsible. They need to know about it if you're not having success. Find a board member that's willing to listen and say, I'm not having any success. And these are definitely issues that are going to impact and have impacted patient care in my experience, and they need to be corrected. And I'm getting stonewalled.
I would add to that by saying this. If you're directly impacted in those deficiencies, if it's your patient and it is a potential harm to your patient, then don't stop, because
right.
not only impacts your patient, but it impacts you. And continue to fight that. And I would couple it with, remember your value. You're benefiting them. They're not doing you any favors. You keep them employed. And oftentimes that's the tact or the approach that we take with our representatives and our lawmakers. They work for us.
Right.
So we should not, oftentimes people say we have a royal class in this country and it's our members of Congress. That's not the way that you walk into that meeting. And don't go in braggadocious or with ego. You want to go in and have them work on your behalf. Many of them don't understand healthcare, and they want to hear from you. You're going to be one of the few people that aren't getting paid to be there. You're there because you care about your patients, you care about the community, and you're there spending your own money and foregoing money you could have made in your clinic so that you can tell them what you believe is right.
I see a question that was asked about medical loss ratio, and in a short description, insurance companies under the ACA legislation, which is now expanded, of course, to everybody else, have a requirement that they pay a minimum of 85%, and typically it's 80%. 80% of the premium dollar has to be spent on medical care. The other 20% or 15% in extenuating circumstances is considered their, for lack of a better term, profit. So the reason that insurance companies have no incentive to lower hospital charges is the more money they get charged, yes, they have to pay 80% of that, as towards medical care, but that 20% all of a sudden becomes a bigger number. So if they're getting $100,000 instead of $80,000 for a procedure, they have to pay the concomitant 80% of that off to charges. They have to actually reinvest that into care. But the more money the hospital charges, their percentage gets bigger, in short. That's how that works.
They're very good about getting to that 80%.
Oh, yeah.
They'll create committees, internal committees, and create a budget for that committee to allocate percentages of that money to get up to that 80%, so they're not leaving anything on the table.
Right.
I think we've come to the end of our time, guys.